All right, so for this case, we have a 70-year-old male who has a past medical history of COPD. He presents to you guys with shortness of breath after inhaling some dust. So, not an uncommon story. You've got somebody with a pre-existing hyperreactive lung disease. They inhale something that's kind of irritating, and now they're experiencing some shortness of breath. So he does what any person with this disease might do if they're feeling a little wheezy. Is he provides himself with a few albuterol nebulizer treatments, and then he activates EMS. When you arrive, you discover him to be feeling still pretty short of breath. He feels like the history is pretty clear cut. He's not vitally unstable, but you do note a couple of things. One, he is complaining of shortness of breath, and anytime we have shortness of breath as a complaint, we're going to get a 12-lead ECG, and we're also going to get a rhythm strip while we're acquiring that ECG. And when we hook them up to the monitor, we see this. And so, right off the bat, there's a couple of things that jump out. Number one is the rate does appear to be greater than 100 times a minute. So he's got some sort of tachycardia going on. And then the rate itself also looks a little irregular. And so you might think to yourself, well, that's kind of strange. I wonder why that is. I'm going to interrogate it a little more. So we'll take a closer look at this rhythm strip and see if we can kind of come up with a diagnosis as to why he's got this irregular tachycardia. So when it comes to a differential diagnosis, especially when it comes to irregular narrow complex tachycardias, it's a pretty short list. First and foremost, when we think of irregular tachycardias, we think of AFib with RVR, so rapid ventricular response, a flutter with variable conduction. I'm just going to abbreviate conduction. And finally, we have multifocal atrial tachycardia, which I'm just going to abbreviate as MAT to save space and to save my own sanity. So, first things first, when it comes to irregular and narrow complex tachycardias, we need to figure out what the atria are doing. That's going to be our clue and our biggest indicator as far as narrowing down what type of tachycardia this particular rhythm could be. And so when we take a good close look at this rhythm, we'll notice that we've got very clear and very distinct looking QRS complexes that are in fact narrow. So again, this reiterates that this is a narrow complex tachycardia. And when we look a little closer as far as what the atria are doing, we're seeing kind of a smorgasbord of what could only be described as goofy looking P waves. And so, because of this regular P wave morphology, right off the bat, we can tell ourselves that AFib is probably not the answer because we do have some pretty consistent uh, atrial activity here. And if this was in fact AFib, we would not be seeing these kinds of complexes being as uniform as they are. Next, our next differential that we need to kind of figure out is whether or not this is a flutter with variable conduction or multifocal atrial tachycardia. And this is actually quite simple. So with a flutter, you would expect to see a atrial rate of 300 times a minute, maybe 250 times a minute if it's being a little on the slow side. And we just don't quite see that here. So we've got these goofy looking P waves that seem to be kind of going in all different directions, but we don't have any clear cut flutter activity. And what does that mean? Well, that means we don't have another P wave, say right here, at what would be the 300 beat mark. A flutter, when you have visible P waves, will systematically show additional flutter waves or additional P waves that map out at a rate of about 300 times a minute, and we just don't see that here. We have an isolated P wave preceding this QRS complex, but the P wave, or rather the complex or the wave before this P wave is in fact a T wave, and we do not see a P wave at what would be the 300 mark if we look at this big box. So, having said that, we can eliminate a flutter with variable conduction. Let's get rid of that. Finally, that just leaves us with the one diagnosis, and that is multifocal atrial tachycardia. If you recall, multifocal atrial tachycardia is a condition predominantly seen in patients with obstructive pulmonary disease or some degree of cor pulmonale. And what you're effectively seeing is the atria producing impulses from multiple foci, which is why you get this varying degree of P wave activity. You've got some inverted ones there, you've got some kind of normal ones here, and then we've got this like spiked, goofy one here. And so by definition, in order for this to be MAT, we need at least three or more different P wave morphologies. And we're just going to say morph because morphologies are hard for it to spell.